Okay, so hello and everyone will be going through the guidelines for blood grouping and red cell antibody testing in pregnancy. These are the BCCL guidelines that are published in March 2016, and they are an update on the previous guidelines which were published in 2007, and they take into account recent advances in fetal medicine such as the widespread use of a non-invasive fetal monitoring techniques like the Doppler of middle cerebral artery, and also regarding the relevant genotyping of the fetus from DNA in maternal blood samples. So just an update on these guidelines and also the reference to the RCOG guidelines. They have also been incorporated. Most of the actually the recommendations made by the RCOG have been incorporated. So regarding the, we just jump right into what the recommendations are regarding the consent and sample taking and request form. So these are important, basically recommendations regarding the consent. First of all, we need to be the consent. It should be, regarding the consent, the sample, and the request forms. So what they have actually recommended regarding the consent is that the consent should be made of the patient is to be taken into account, and the sample should be taken, should be an informed consent. Should be the issue should be basically told about the what the implications of the testing would be, and then the sample should be taken at the bedside of the patient, preferably and labeled there as well, dated, labeled, and signed by the person taking them in the presence of the pregnant woman, and who should, whenever possible, be asked to state her full name. So the credentials basically for these are that her full name and her date of birth, they should be recorded. So most the patient identifying, of course, the MR number can also be recorded. The sample, then the phlebotomist also needs to sign the and should sign the request form and the and should then record the print the sample should be then labeled by the bedside, signed by the phlebotomist, and then time should be noted, the date and time noted. And then the laboratory request, basically all the laboratory testing should be in compliance with the published guidelines which have been previously stated in 2012 regarding the laboratory testing procedures. So basically what they've told about the ABO and D typing is that the ABO blood grouping needs to be performed in accordance with the guidelines for compatibility testing. These are previous guidelines that we will go through probably in some other stage, but these have outlined all the guidelines how to do the ABO and the D grouping of all the samples. But with special regard to the ABO and D typing of pregnant women, these guidelines, they add on to those guidelines, and they have classified that, they have stated that all the D types, basically the D blood group, that is all those patients who type as D negative, they should be, their D, the DU testing should not be done, because that would actually those patients should be left as being classified as D negative until the D status is confirmed. All pregnant women found to be D negative should be given written consent about their D status, and the implications of this regarding the anti-D prophylaxis, they should be recorded, they should be informed, but the patient should be informed about it, and it should be recorded, and then the necessary action should be taken. And basically also the physician should be informed about this. So now screening for red cell antibodies, basically first we have taken the sample. It's basically first of all this informed consent of the patient, then the sample being taken by the bedside by the phlebotomist. Is phlebotomist notes down the time that sample was taken, and also the patient credentials, that is regarding her name and date of birth and the MR number of the patients. Then also the after the consent, the request form should also contain a brief history of the patient, that is regarding the current pregnancy, the duration of a current pregnancy, and also the any history of HDFN, any history of transfusion that is being given in this pregnancy or at any other time in previous pregnancies, and also any history of any anti-D being administered. So anti-D administration, transfusion, and pregnancy history, previous pregnancies and the current pregnancy, all history regarding these should be recorded in the request form. And then also they should regarding the antibody administration also, four things need to be actually updated there regarding the dose and the date of administration, and also the route and the um, reason for administration of anti-D. If anti-D prophylaxis had been administered, then that would of course affect the results of the D testing. So this should also be stated on the form. So regarding anti-D administration, we should ask these four questions, pertinent questions. Then regarding transfusion, we should need to ask about how how long before had the transfusion been given. That is the duration from the transfusion to the time of testing. So we can also have an idea of whether it's more than or less than 3 months, or whether it was a recent or a uh, very or a transfusion had been given very long ago. Then also we need to, regarding the pregnancy, we also need to include about any sort of procedures like amniocentesis or chorionic villus sampling that had been done in those patients. So this all history needs to be recorded in that form. So the phlebotomist needs to take the how to phlebotomist needs to take the sample, then what the credentials of the patient should be entered, then what history should be recorded in the request form. They've all been outlined. Now, once the blood, the sample reaches the uh, once the sample reaches the blood bank, then it should be ABO and D-typed as no as all as routine samples. But regarding the D-typing, they have mentioned that D-typing of these pregnant females, if they if the type is D negative, then further DU testing should not be done. Then they should be labeled as D negative, unless unless the confirmatory sort of their confirmed status is not known. And if they are D negative, then they should be informed about this. If the patient should be informed, and the clinician was requested should also be informed, so that they can take the necessary action. Then also of course, then the clinician would sign out a request for antibody screening. The screening should be in compliance with the procedures that have been labeled out as with all other screening cells. They should be done with accordance with the BCS guidelines of 2012. They mentioned it and there is here they have mentioned that screening should be done in due to and screening should be done for those normal panel cells, that is due to poor reproducibility in individual cases and a relatively low incidence of severe disease in the UK population. So testing for a high concentration of immune anti-A and or B in pregnant women is not recommended. And there is no additional value in using an enzyme treatment method. So enzyme treatment methods for antibody screening, we do not need to go in for enzyme treatment methods. Because we do not want to detect clinically insignificant antibodies, because enzyme treatment method would actually bring out some clinically insignificant antibodies. However, if the antibody screening is positive, that is, if an screening panel shows a positive result, then most likely that antibody is significant. So we need to proceed further with the antibody identification part. Now, this antibody identification should also be done according to the rules of the 2012 guidelines, and they have mentioned that at this part, if any antibody is detected, then this should be further classified, and the type of antibody should be stated. And at this stage, however, to ensure that all antibodies are identified, because we need, and because the patient would be on monitoring also, so we need to go the antibody identification needs to be done really thoroughly, because all antibodies that may be identified, they need to be mentioned. So at this stage, antibody enzyme treatments may be used to actually elute the antibodies from the samples. And so we so they have actually mentioned here that additional samples taken to identify and exclude any additional clinically significant maternal antibodies, such as women who have developed an antibody or at a greater risk of developing additional antibodies. So those additional tests need to be done. And at this stage, because if any of us women has an antibody that has come positive in the screening stage and has been identified in the antibody identification stage, then we cannot actually rule out the presence of other additional antibodies. So here also, a repeat test may be taken for antibody screening identification. and they will also depend on the specificity and the strength of the antibody. Now, regarding the antibody, basically, whenever an antibody is identified, we need to be need to classify whether it's clinically significant or not. For that purpose, we will go into those clinically significant antibodies are mostly the anti-D, small c, and KEL. These are those antibodies which are significant in pregnancy, and the aim of antibody testing in pregnancy is to identify those antibodies which can cause HDFN. So the clinically significant ones are anti-D, C, and KEL, which need further monitoring. And of these anti-D and small c, they need to be quantified using a certain specific equipment. Now, this specific equipment is a continuous flow analyzer, which will the continuous flow analyzer will basically measure the antibody concentration using national standard. They are mentioned the NIBSC standard, which is used for the quantification, and the results are reported as international units per milliliter. So the results are reported as international units per milliliter in these reports. And so this is what we needs to be done for the anti-D, and so this is what needs to be done for the anti-D, and this is what needs to be done for the anti-D and C antibodies. That is, they are measured using those continuous flow analyzers, and they are measured and using the they are measured using continuous flow analyzers. This is the special equipment, and then their national standards are used, and the results are measured in international units per ml. And we also go into the details about how the results, the values for anti-D and C, how they vary according to the pregnancy. Now, wherever possible, each sample should be selected in parallel with the previous sample. And then also this another thing that is needed, that first, this is the how the antibody is quantified, and then another thing that the report should also mention is any previous report that result that has been obtained, and then we should compare the antibodies so that's to know a trend in rising and falling of the antibody levels. Then also we need to know about the antibody titer. That is now this is the technique that is used for for other antibodies, and they are mentioned here the antibodies like KEL and Duffy, and also FIA and JKA. So KEL, Duffy, all those other antibodies that may be causing HDF, clinically significant antibodies other than the anti-DNC, they are measured by doubling dilution method. So you have 1 in 2, 1 in 4, and 1 in 8, and so on, in 16, 32, and so on. And out of the and now the various guidelines to go about this is like we have the same as we have for above. We'll be highlighting those how we actually go about this is that first we'll be doing the doubling dilution is done using phosphate buffered saline, and we go up till the I8 stage, and this is the phosphate buffered saline is added to the patient's plasma. The plasma is taken, and we add the reagent red cells which are which show the heterozygous expression of the they show the heterozygous expression of the corresponding antigens. So this is important that they have heterozygous expression of the corresponding antigen, and after that so doubling dilution is done, and this is done for antibodies other than A, and they use the heterozygous expression of cells using the phosphate buffered saline. We dilute it when doubling dilutions first the plasma. So first we have this plasma that is added to the reagent red cells, which are of course the heterozygous expressing antigen cells, and then we double diluted by adding a phosphate buffer saline. So phosphate buffer saline is added to this in doubling dilutions. And then we should go up till the I8 phase. This is another recommendation for doing this test. So we go up till the I8 phase. And then care must be taken in selecting the cells for titration. More than one antibody may be present, so we have to of course, when we need heterozygous expression of cells, so they have actually mentioned a brief example, that is, if you have anti-K positive and and if you have anti-K and Duffy Y, Duffy A present, then we titrated them against two panels of cells. One should contain the heterozygous expression of the Duffy A with the KL negative and FIB also positive, so you have heterozygous expression of Duffy A, and another panel with the heterozygous expression of the KL antigen. So this is with heterozygous expression of the for both these antibodies. We will then have heterozygous expression of the Duffy antibody and heterozygous expression of the KL antibody, that is big K and small k, and Duffy A and B in one panel. The other being negative. In this case also the other is negative. So this is how we go about doing these heterozygous expression panels are used. And then we need another thing that they've mentioned is also the careful that we need to do in order to minimize any sort of variables. It is recommended that the anti-D standard should also be titrated along with this. So in this case, previously we had to go about the equipment, the continuous flow analyzer, that had to be that had to, the equipment was first of all calibrated, and we use a national standard for the measurement of against which the antibody concentration is measured. In the case of titration of antibodies, the phosphate buffer saline is used to dilute the antibodies by the double dilution method, and we use cells with heterozygous expression of the antibodies, and then and then for in this case the controls are actually the anti-D controls, which are run in parallel, which are titrated in parallel as internal controls to ensure reproducibility of in-house effect of results in-house. And then also the results are then reported as the reciprocal. I mean, whenever we get the highest dilution, which gives a 1+ reaction, is then taken as the is just taken as the endpoint, and then the result is reported as the reciprocal of this highest dilution. And so if we have if we have a dilution of 1 in 32 showing a positive reaction of 1+, there is the result will be reported as a titer of 32. So they've actually mentioned that and also along with this, after we have titrated this antibody against the double dilution method, we need to report this antibody as the titration value. And this is also then, we also need to mention the phase in the medium, the technique that was used for to identify it, whether it was a tube technique or a continuous agglutination technique or a solid phase medium. So if whether it was gel, solid phase or tube testing, we need to also mention that on the alongside the report, because the value would then differ according to the different types of techniques that have been used to titrate it. Now this was all regarding the maternal sampling. The maternal, first of all, we had to take the consent of the patient, then the sampling of the patient had to be taken bedside, then the report form, then the report request had to be fully entered with a brief history of the patient. Then when the patient, when the sample receipts reaches the lab, there is need to go for both the a full sort of profile of the patient regarding the ABO and D-typing. And regarding the D-typing, they mentioned that we should label these D negative patients and inform the patient as well and the clinician about the implications of a D negative pregnant female. And then regarding the antibody identification, we need to go into details about the antibody screening of the cells, and then if the screen comes out to be positive, then there's need to go about antibody identification. And this we need to go we need to do to exclude all significantly to all significant maternal antibodies. So we may need to go into even additional tests at this stage. And those antibodies that are identified, the most likely they've mentioned antibodies like anti-D and C that are anti-D and small c that are most commonly quantified using the continuous flow site analyzer. And this uses the national the standard. Firstly, the equipment is the flow analyzer. It uses this national standard of by the NIBSC control, and then the results are labeled as international units per ml, and they are then compared with previous sample or results that may have been obtained. Then regarding those clinically significant antibodies other than the D and C, we need to go about doing doubling dilutions, and for this there is the we need to have the patient's plasma, which is used, which is reacted against the heterozygous cells, red cell reagents, which have heterozygous expression of the corresponding antigen. And we use phosphate buffer saline to go about diluting the samples in 1:2 and 4 and 8 and 16 dilutions. And then we take this test up till the I8 phase, and then the results, which when they are positive for 1+ reaction, we then report this result as the positive as the endpoint of our titration method. And this is then the reciprocal of the highest dilution is then the reported titer. We also need to go about in an internal control. And in-house control would be an anti-D standard run in parallel with this as an internal control. And so any increase of dilutions of in more than one dilution, any increase in more than one dilution, that is a rise from a 2 to in a subsequent test to a rise of 8 would be considered to be a significant rise. So if you like miss one, if you have jumped from one value like a 2 from a 2 and you jump from 4 to an 8 dilution titer, so this more than one dilution, that is if you skip from 2 to 4 and then more than one would be an 8 dilution, this is considered as significant, as a significant rise. And then the we need to inform the clinician about this as well. Now also we need to mention that the technology that had been used regarding the whether it was a gel or a tube testing or a gel or a solid phase testing. Now this is all about the maternal part of it. Now we come to the paternal testing. These guidelines have mentioned that the paternal testing should be considered to predict the risk to current and future pregnancies, and this is considered as a this is now more now with fetal genotyping being available using cell-free fetal DNA. So we may even avoid this testing of paternal antibody testing. But they have mentioned that if potentially clinically significant maternal antibodies have been identified, potential paternal testing should be considered to predict the risk to current and future pregnancies. So basically regarding the current pregnancy, even if the fetal genotyping is done, that is if the mother is D negative and the fetal genotyping shows that the fetus is D negative, then that is significant a sort of a sign for the physician to be informed and to continue with fetal maternal monitoring for HDFN. But the paternal testing is more important for future pregnancy, so that the mother can be warned of any sort of an antibody that she has likely to be due to that may show homozygous or heterozygous expression. If there is any sort of a paternal antibody which may show homozygous or heterozygous expression, so that would actually be of clinical significance to go about paternal testing in these cases. So regarding the fetal genotype, now first we had the maternal phenotyping and then the paternal phenotyping, and now the fetal genotyping needs to be done, because this genotyping is important, because we need to be very sure that the fetus who is now going to be monitored is actually a D negative D positive fetus in a D negative mother. So the fetal genotyping to confirm the genotype of the fetus is used. First of all, there were techniques for amniocentesis and chorionic villus sampling, but now maternal cell-free fetal DNA from the maternal sample can be obtained from as early as 16 weeks of gestation. So this has now become a routine use, and this is important in basically in cases where um, the pregnant mother has either a significant antibody, clinically significant antibody, or has a previous history of HDFN. And this is also important if the father's antigen status is either unknown or that he expresses the corresponding antigen. That is, if he expresses the corresponding antigen either in a sort of a homozygous or heterozygous manner. If there is a heterozygous expression of the antigen, then we will have to confirm the fetal genotyping to identify the risk in the fetus. And if there is a homozygous expression, then of course, then the fetus would be considered if there's a homozygous expression of the corresponding antigen in in the father. Then of course the fetus is at risk of HDFN. So now this cell-free fetal DNA is obtained from the maternal serum, and this is they have actually identified even certain laboratories that do it, and actually those laboratories which go about doing it in large volume testing, they have very good results with about less than 1:3 to 1:0.1 to 0.3% false negative rates. So the rates are very low for those labs which have large volume testing. For and they are able. This is available mostly for the anti-D and C, and also for the Kel star on one is as phenotype. But this Kel assay, the Kel star one phenotyping, which detects a single nucleotide polymorphism in the fetus, has a particularly close cutoff range between positivity and negativity. So the values of this Kel antigen assay are also to be to be taken into account only when they're done from labs which have a large volume testing facility. So it is important where these tests are sent for this cell-free fetal DNA is sent for testing. So we should identify labs that have a large volume testing, that have the expertise to go forward with the testing of these samples. And we should also first confirm with the lab whether they have facilities to whether they accept samples at which stage of gestation. For example, there may be labs that accept those samples at 17 weeks of gestation and so forth. And they may have values for this for the cell-free fetal DNA at certain weeks of gestation. So although even as early as 11 weeks we may send this sample for cell-free fetal DNA, but we need to be very sure about the capacity of the lab to identify it. So we need to have the anti-D, for example, Kel may be identified after 17 weeks, and if we are going for an D or CH assaying, then that may be carried down after 16 weeks of gestation with less than 1% of false negative results. So regarding which antigen we want to get the assay done for, we need to specify with this, and at the current time, mostly the D, small c, and Kel antigens are the ones that are routinely being offered by these labs for cell-free fetal DNA testing. And of these, the Kel type has the one that has basically has a particularly close cutoff between positivity and negativities. So whereas the D and also this needs to be sent at about the 17 after 17 weeks of gestation, whereas the D and the RHC, they can be the samples can be sent after 16 weeks of gestation. So the fetal genotyping is then going to be important to identify whether that female needs to be given anti-D or not during her current pregnancy. And for mass throughput screening of all D negative women, cell-free fetal DNA testing for RHD is sufficiently accurate from 11 weeks of gestation onwards, with a false negative range of 0.1 to 0.3%. Now, this is all regarding the how the fetal genotyping is done, and what labs what we need to know about the capability of the lab to identify certain labs. They should be uh, uh, their um, uh, their competence regarding the voting of these self-fetal DNA should be taken into account when sending these samples to labs for testing. Now we come to the protocols. Basically, the first we were just going through the different testing methodologies. Now other testing protocols. That is which antibodies we are clinically significant, and how frequently they need to be monitored during pregnancy, and also what is the what should be then offered to those females. Now regarding pregnant women who are D negative, they should be offered the prophylactic anti-D administration, and this should be done um, after their screen comes out to be positive for any sort of for D or C or small or KL antigens. So there is evidence that antibodies first detected after. Now another thing that we need to know about regarding these antibody testing is that it first needs to be, it is recommended that it is done at booking and then at 28 weeks. But those antibodies which come out positive at booking, they are more investigated and of course treated more vigilantly, because those antibodies which are of course were earlier in pregnancy would then we expect them to rise during the course of pregnancy to much higher values, whereas those antibodies which are detected at or after 28 weeks of gestation, they most likely are not very clinically significant antibodies, or they may, or we although we do monitor them, but we expect they may actually even their titer may decline through the course of pregnancy. So in D negative women, the 28-week sample should be undertaken before the administration of at 28 weeks, the sample should be taken before the routine administration of this routine antenatal anti-D prophylaxis, because otherwise that sample would contain the antibody testing sample would then contain the passive antibodies of the anti-D. So, in pregnant women with no clinically significant red cell antibodies capable of causing HDFN present at 28 weeks. So, those who do not have any antibody at booking and at 28 weeks, they have no further testing is needed. But for those that have no antibody at booking, but they show some antibodies at 28 weeks, first we need to actually go into the history of whether of the anti-D and anti-D immunoglobulin, if it might have been administered to the patient, the time of the administration, and also the route and the dose, and of course all the details about the anti-D administration need to be taken into account. And we actually even need to inform the physician that the sample of 28 weeks has to be taken before the administration of this anti-D, because otherwise this the anti-D which comes positive after 28 weeks would most likely be treated as passive anti-D rather than immune anti-D. So and if however if a sample comes out positive at booking and then is of course again positive at 28 weeks, then that would be clinically significant, because its titer would we expect it to rise further during the course of pregnancy. So red cell antibodies now, so first we have taken into account that when these antibodies are reported, we need to take into account the time line, or at the time period at which they are reported. And also for women who have, so basically at booking and at 28 weeks, we need to get this antibody done. But for women who have had a previous history of a baby affected by HDFN, they should be referred before 20 weeks of gestation to a fetal medicine specialist. So for these pregnant women with the history of HDFN, the alarm bell actually starts ringing even before the booking, which is usually done at around about 8 to 12 weeks, or and they are referred even before the 28 weeks period has come by, because they need more stringent monitoring. So this is basically a guide to the procedures that need to be done. Antibody ABO and D-typing and antibody screen needs to be done in all pregnant females. Now, if the screen comes out to be positive and it shows clinically significant antibodies, then we proceed along these lines. If there are no clinically significant antibodies, then we will just need to do a repeat testing at 28 weeks, and if that is negative, then no further testing. Whereas though for those who have an antibody that was negative in the beginning, but at 28 weeks clinically significant, then we again move on to the this algorithm of clinically significant antibodies at booking. So for clinically the algorithm is basically at booking and at 28 weeks. If both are negative, then no further follow up or basically action needs to be taken regarding the antibody uh, checking. So, but if an antibody is negative at booking but comes out positive at 28 weeks, then we will again consider it along these lines of whether it's an clinically significant DEC or KEL antibody or any other antibody. Now, if the screen is positive at booking and it shows an antibody identification is done and it shows it that it is D small c or KEL positive, then we need to consider fetal and paternal phenotyping and fetal genotyping. And then the monitoring would be that is monthly till 28 weeks and then 2 weekly until delivery. And for all other antibodies, it is again just for these are the clinically significant ones. For other clinically significant antibodies, we will just need to go do those antibody screen at booking and then at pregnancy. And then if it is positive at repeat screen antibody screening at 28 weeks gestation, is if it is again positive, then we need to also monitor them along the same lines and then go out doing the testing at cord blood sample level as well. Now a more detailed flow chart for the algorithm, if we take into account the D, C and K antibodies, then an important thing to be taken into account is that the D and C are the antibodies which are quantified according by this continuous flow analyzer. So the values are two important values that we have here are those the 4 and 15. So if the values are less than 4, then they are unlikely to cause HDFN. If the anti-D values are between 4 and 15 international unit per ml, they are moderate risk, and more than 15 have severe risk of HDFN. For anti-C, if we have values of 7.5 and 20, which is clinically significant, less than 7.5 is unlikely to cause HDFN, 7.5 to 20 is moderate risk, and more than 20 is severe HDFN. And for anti-KEL, we already know that we need to titrate the antibody. And for anti-KEL, if anti-KEL is or any other KEL system antibody is detected, then we need to titrate it. And for this, they have mentioned various references have been made regarding titer of 32 or a titer of even 18 or so such, which may be detected. But most of them recommend that even if it is any titer at which it is positive, the algorithm would remain the same. That is, the same frequency of testing would need to be carried out. And also we need to be we need to test the father whether now in all these cases there should be a prenatal diagnosis by the genotyping method and the paternal testing to show the to test whether there is homozygous or heterozygous expression in all of these cases. Now, if there is heterozygous expression, then of course there is a we need to confirm the risk to the fetus by going about doing a self-repeated DNA. Whereas if there is a homozygous expression of the corresponding antigen in the father, then of course the fetus would be at risk of HDFN. So in all these cases, the homozygous expression of any D, K or small c puts the fetus at increased risk of HDFN. And also if the cell-free-fetal DNA shows that the fetus is KEL positive or D positive or small c positive, then also there is risk of fetal HDFN. So this is now the algorithm that needs to be followed at the fetal medicine specialist centers. That is, they go about doing the fetal ultrasound by the Doppler middle cerebral artery technique, and they need to actually monitor the middle cerebral artery flow, and another an intrauterine transfusion. So these are three things that will be done at a fetal maternal specialist. First of all, they would go about going along with the antibody uh, titer that would need to be monitored. So the antibodies, so this as a fetal medicine specialist center, the antibody titer is monitored, the fetal cell-free fetal DNA assay is confirmed to assess the risk in the fetal DNA, and the fetus ultrasound using middle cerebral artery Doppler is done. And if intrauterine transfusion is indicated, then it should be arranged for. And also another thing that they would stress upon is the delivery at 37 weeks of gestation. And then they need to go about having a cord blood hemoglobin, um, bilirubin, and that. So the maternal blood group is sample is also sent, and a cord blood sample is also sent to assist in the management of HDFN. Now we need to identify the hemolysis in the newborn, and for that the cord blood would show about any sort of anemia if it is present, that is hemoglobin, and bilirubin and LDH would show any signs of hemolysis, and that would show the immune nature of the hemolysis, and therefore more likely to be predictive of hemolytic disease of newborn due to these antibodies. Now the procedure to follow where D negative, where anti-D is detected in pregnancy is we need to actually determine whether the anti-D has been administered or has been just. So basically what they have stressed upon is that when there's fetal maternal, when the antibody is detected, we need to know about the titers of these antibodies, and whether they have moderate or severe risk, and also regarding whether there is any this will predict the risk of HDFN. And another thing that needs to be taken into account in these cases is not just the titer, but also the administration of anti-D, whether it has been so all in pregnant women with who have these anti-D, detectable anti-D, we need to one thing regarding the anti-D that we had mentioned earlier in the protocol. In this protocol is that if anti-D is mentioned, or not only we need to be very cautious about the titers, but another thing that we need to know, even if the anti-D is less than 4, maybe at booking or at 28 weeks, then another thing that needs to be that is especially that is of special interest in anti-D detection is the fact that whether the anti-D is immune or passive. So this is another dilemma regarding the anti-D. We will talk about certain specifications regarding anti-D first, whether this anti-D, which titer it has, and also whether it is immune or passive. And there'll be certain clues in the history that will suggest whether it is immune or passive. Of course, and one such clue in the history would be whether it is whether an anti-D had been administered to that patient. So if an anti-D had been administered, if the anti-D is identified in maternal plasma, then we need to take into account whether an anti-D had been administered, and also whether its level is less than or more than 0.4. So if it is less than or equal to 0.4, and if an anti-D had been administered, then this is more likely to be passive immune. A passive anti-D. And if the anti-D had not been administered in this pregnancy and the value is found to be more than 0.4, then we should treat it along the lines of a immune antibody. So this is another thing that they have highlighted, that the levels they have mentioned for 4 and 15 for anti-D, they are significant, but levels also less than 4 should be taken with caution, and we need to have a history of whether the patient had been administered anti-D and whether the level is between in the range of 0.4 to 4 international unit per ml, and whether and at which time frame the antibody had been taken. So four things need to be taken into account. That is whether the anti-D, we have a history of an anti-D administration, and the level the level at which it is detected. So the level at which it is detected, whether we have a history of anti-D being administered. Then also if the sample is taken prior to 28 weeks, that is before 28 weeks, if this if this sample had been taken before 28 weeks, and that would also suggest more likelihood that the sample that the such an antibody is immune in nature, and that it will rise during this course of pregnancy, and therefore may put the fetus at risk. So anti-D detected at or before 28 weeks will only be identified in a relatively small proportion of pregnancies, but it poses a greater risk of rising in level as the pregnancy continues and cause significant HDFN if it is immune. So, so even if this antibody, at this stage, we can only predict that such an antibody whose level is less than 0.4, and whether it has been a history of anti-D being administered, and whether and if this sample is taken prior to 28 weeks, then we can just assume that it is more likely passive in nature. But just to be on the safe side, we will treat treat it as immune. So these are those cases that need to be treated as immune if the such cases are positive. So even though maybe most of them are passive, they may be immune, and they should be monitored as such. So the monitoring should be, so basically regarding the monitoring, it should be done like 4 weekly till 28 weeks and 2 weekly until delivery. And these should then be treated as an immune as well. That is, the anti-D should be administered. That is, if the level of anti-D is less than 0.4, anti-D should be administered in accordance with the BCG guidelines of anti-D administration. Now, if the now if we have a sort of if we don't have any sort of documented history of anti-D being administered, and if the value is and if the sample is like taken after 28 weeks of administration, and anti-D had not been previously identified in that sample, and now just after 28 weeks of gestation, the value comes out to be positive, then more likely, and if the level is also less than 0.2, if the level is also less than 0.2 international units per ml, then it is most likely to be it is certainly passive. This guidance says that it is certainly passive. So in this case, when the sample was taken when it was taken prior to 28 weeks, and there is a history of anti-D levels being very low, or anti-D have been administered earlier in the pregnancy, then for these there is only a chance that it may be immune. But even if it may be immune, we still need to go about the same monitoring guidelines and the same treatment guidelines. But for an antibody that is detected after 28 weeks and the level is also less than 0.2, then it is most certainly passive, and we need to then, no follow-up is then recommended. However, if it is detected after 28 weeks, and anti-D had been previously found in that sample, or this quantity is more than 0.2, then it may be immune, and so we'll proceed research. So these guidelines basically to differentiate between immune and passive are important, because if we consider an antibody, we mistakenly misinterpret an antibody that had been actually passive in nature, and we um, uh, actually consider it as immune in nature, we may go about giving unnecessarily anti-D to the patient. So, however, if the if the anti-D that has been detected is actually immune in nature, and but it is considered passive, then we may consider not monitoring it, whereas and it may rise to very high levels during the course of pregnancy, so that would actually pose a risk of HDFN. So these guidelines, this is an important chart that needs to be taken into account regarding which antibodies to consider as immune and which to consider as passive. So to be on the safe side, although we know that from our history that antibodies which are less than zero point 0.4 are most likely to be passive in nature, but if there is a history of anti-D administration and the sample has been taken before 28 weeks of gestation, then we need to still consider it as immune, and we will then go along the same lines. However, if the sample had been taken after 28 weeks of gestation and there is no previous history of any previous sample being positive for anti-D, then and if the level is also less than zero point 0.2, now these are other these pointers are uh, further signs that it is most certainly passive, and so then we can make such further testing in these on further follow-up of these patients. And then also regarding the so this is again all the repetition of which antibodies need to be considered as passive and which are considered as immune antibodies. So regarding anti-D, there is one slight warning that they give, that we should not only the levels which are significant levels for anti-D, they should be taken into consideration, but levels less than 0.1 international unit per ml, we should consider those whether it's passive or immune. We should also keep in consideration mm, such values of whether they are in the zero point 0.4 to 1 international 0.4 to 4 international units per ml, or whether they are less than 2.2. And then they should also basically what they have recommended is that if anti-D had been administered, the laboratories should keep a record of this, and if anti-D is detected, then it should be measured by continuous flow analyzer method. And if there is a doubt as to whether it is immune or passive, it should be monitored like an immune antibody. So we should be on the safe side, and we should monitor it as like an immune antibodies. And other certain guidelines that I've given for immune antibodies is that if the titer is if the antibody is detected prior to 28 weeks, and if after 28 weeks but the titer is more than 0.2, then we should actually consider them as immune antibodies. Now, this was regarding the anti-D antibodies. And another thing regarding the anti-D antibodies is that if these antibodies are not detected, if there is anti-D is detected along with the C antibody, then it would actually give advanced, it can be demonstrated by advanced serological tests to be anti-G or anti-C plus G, rather than just straightforward anti-C and G. So if we detect D and big T and big C, it could also be an big C and G or B or anti-G antibody. So these women also they have mentioned that not only regarding the immune and passive protocol, we also need to go about documenting other antibodies like the big C or which may be present alongside the anti-D, and it is if such an antibody is present, then these cases should also be it should be identified. It is important to identify these cases and to ensure routine follow-up and access to anti-D prophylaxis. So even these cases which are anti-D which are anti-D plus plus big C positive, they should be identified as whether they do have an anti-G and anti-C plus G as well. So advanced serological techniques need to be taken into account, and they should be offered prophylaxis as well. So not only whether the levels need to be taken into account, whether they are immune or passive, but also the antibody other associated antibodies need to be taken into account. Now those with regarding anti-C, this is the same protocol, the same frequency of testing, and the same vigilance. Just the levels of anti-C which need a referral are different for this. That is, for the anti-D we had 4 and 15. And for anti-C, we have this 7.5 and 20 cutoff range. And again, this is the same antibodies that need to be followed up. But that is 7.5 to 20 are moderate risk of HDFN, and more than 20 have high risk of HDFN. And no other special thing about a small anti-C. But regarding anti-KEL antibodies and all other, if there is any anti-KEL, then also we need to take on or other KEL blood group system antibodies. It may be a small big K or a small K, KPA, KPB, JSA, JSB. So any such other antibodies needs to be also identified. It has been stated in and the most common such cause is that they may not have a very much of a hemolytic component, but fetal anemia is associated because KEL antibodies cause inhibition of K positive erythroid cells. So the K positive erythroid early progenitor cells, they are the ones that are affected. And this could then lead to, even if there is low hemoglobin, they may lead to elevated amniotic or cord blood bilirubin levels. So this is another thing about KEL antibodies. The way they cause anemia, they cause fetal inhibition of erythroid precursor cells, K positive erythroid early progenitor cells. So for these special thing is that the antibody serial. So another thing would be that here we do not have a quantified titer, but we have those antibody titration done, and for them we had mentioned earlier that the titer of at least 32 is needed to be classified as severe HDFN. But some also mentioned that a titer of even 8 and above is mentioned is a moderate risk for HDFN. So at least of for severe HDFN is associated with antibodies with a titer of at least 32. But samples from these women should be titrated when the antibody is first identified, and serial titration should be undertaken 4 weekly, and the monitoring is the same, 4 weekly until 28 weeks, and then 2 weekly until delivery. And then referral should be made to a fetal medicine specialist. And there also after the referral is made to a fetal medicine specialist, then the antibody is routinely identified, but it is not quantified in all the cases of NTD, small c, and KEL, because the titer is not very important, but now the fetus needs monitoring for any sort of fetal anemia. And with special reference to KEL antigen, there is another thing like regarding the KEL star 01 status of the fetus. That is, if any fetus is identified with this, then the status of the fetus of pregnant women with anti-K should be determined using cell-free fetal DNA from a maternal sample if the father is heterozygous for the KEL antigen. So if the father is heterozygous for the KEL antigen, or if his antigen status is unknown, then we need to identify this in the status of the fetus regarding this antigen needs to be taken into account. So regarding the KEL antigen, even if his father is heterozygous, then and the cell-free fetal DNA should be used to identify this antigen in the fetus. And for other antibodies that are other than D, C, and K, all other significant clinically significant antibodies like the like anti big C, E, big E, FIA, and FIB. These are also clinically significant antibodies, but they just need to be monitored at booking, and then at 28 weeks. And a decision should be made regarding the more frequent testing of women with the previous history of child with HDFN. So if there is a previous history of a child with HDFN, then only they warrant some sort of a more vigilant screening. Otherwise, the system for anti-D, small c, and KEL has been identified, but for other clinically significant antibodies, just at booking and at 28 weeks, unless there is a history of HDFN in the previous pregnancy. So this is how we need to go about reporting these antibodies. That is So one special thing about NTD was we need to be very certain about whether it's but not only the titer but also whether it's immune or passive in nature, and also a word of caution about the anti big D with an anti C. So that would also need anti D prophylaxis, even if it need to be a special type it for anti G or anti C plus G, especially because if any sort of a blood transfusion may be needed, we need to have them pre-typed as containing these antibodies in addition to D or in association with D. That is, D plus C would act as an anti-G and anti-C plus G. Then regarding anti-C, there is no special reference made, just the titers need to be important. Regarding anti-K, of course, we'll go about about doing the double titration method, and then antibodies more than 32 are severe risk. And for this also, if the father is heterozygous, if the father is heterozygous, and the cell-free fetal DNA should be done to determine the KEL star 01 assay, which because these are the fetuses which need to have vigilant monitoring, even if the father is heterozygous for expression. So then also these samples would pregnancies would need also to be monitored even the fetal medicine specialist center. And I think this is all about. And then also for other antibodies, we do not need to go about routinely monitoring them unless of course there has been a history of if there is a history of previous child with HDFN. And in the absence of a history of HDFN, even the likelihood of developing high drops with antibodies of other specificities is less than other than D, C, and K. So we need to take into account only those pregnancies which have titers more than 32, and also women with anti-E, and those who had hemoglobin low at delivery and hydrops fetalis, so they were actually monitored. But there are no further recommendations in the guidelines to go about further testing them if there is no history of HDFN. So based on this, only those which have which have a history of HDFN and for whom the value is more than 32 at those with a higher titer or those with a history of HDFN, only those merit referral to a special medicine center. So for antibodies other than D, C, and KEL, only the titer and the history of HDFN, that is important. Now the actions at the time of birth, the actions at the time of birth is that firstly the maternal sample is taken and a cord blood sample is taken. Now the maternal cord blood sample should be taken. What we need to do on the cord blood sample is that we'll go about testing the D group of the D group. Basically, the D group is done. AB forward typing is done. Blood grouping by D group is identified, and then the if the fetus is if there is minimal evidence that if the fetus expresses the DVI antigen and the by normal D reagents it comes out to be D negative, most centers would not they do not recommend the DVI typing for these patients to as it is not recommended, as the risk of using wrong reagent for routine blood testing outweighs the risk of missing a DVI positive cord sample. So this is another thing that they have actually mentioned in these guidelines, that even first the maternal sample and cord blood sample should be obtained, and the cord blood sample, what needs to be done on the cord blood sample is that we need to go about doing ABO and D-typing. If the fetus comes out to be if it just comes out to be as if if the fetus shows a D negative, we do not need to go about testing for the DVI antigen, since what they have actually suggested here is that the risk of the wrong reagent, of the using the wrong reagent for routine testing outweighs the risk of missing a DVI cord sample. So even if the antigen, if the antigen, if the DVI antigen is there, we do not need to identify this and label the patient as D positive, because most examples of weak D antigen, they can be easily detected by selecting high affinity anti-D reagents. So we can, if we have weak D antigens, they can be selected using high affinity weak D anti-D reagents. But we do not use those reagents routinely to identify these fetuses. So for DVI, actually the partial Ds are not, so as a fetus, the partial D needs not be identified, but the weak D, they can be detected using high affinity anti-D reagents. And then that is also done on the corporate. So not only do we do ABO forward grouping and D typing, in which case the DVI antigen is not routinely tested, but the weak D is detected. But we also go about doing a routine DAT on these samples, and the DAT on these samples it needs to be done, and it has been shown that following the random anti-D administration, anti-D anti-immunoglobulin can cross the placenta and enter the fetal circulation and bind to fetal D cells. Consequently, 3 to 6% of the D positive cord samples have been found to have a positive DAT. So a positive DAT in a cord blood sample, we need to take into account whether the anti-D had been administered at the time of delivery. Because if we do not have that positive history, we may go about unnecessarily addition investigation. So if we do not have that history, we may go about unnecessarily testing the sample. And there is evidence that prophylactic anti-D does not cause significant hemolysis of neonatal RBCs. So the DAT needs to be done, but the strength of the DAT and the history of anti-D, they need to be taken into account. Now, testing of cord and babies of the women who have the IAT reactive red cell antibodies, when the maternal sample has been found to contain an immune IAT reactive um, uh, red cell antibody, the red cells from the cord should be tested for the corresponding antigen. So not only we do ABO and D typing and of the sample, but also a DAT is done along with the HB and the LDH and bilirubin. If the DAT is found to be positive, we need to rule out whether whether it was an hemolytic immune antibody or not. And if the maternal sample has been found to contain an immune reactive antibody, then the red cells from the cord should be tested for the corresponding antigen wherever possible. And that should be performed on the cord sample, and hemoglobin concentration and bilirubin should be checked. So this DAT and hemoglobin and bilirubin sample checking, it should be done. In addition, the baby should be monitored for clinical signs of jaundice. So the baby monitoring and the HB and the bilirubin and LDH, they should be monitored in the child. If the mother had been found to have a clinically significant antibody, then the cord blood needs to be tested along this DAT and hemoglobin and bilirubin and LDH values. Whereas routine DAT sampling on the cord blood is done only for D positive babies born to D negative mothers with no red cell antibodies. There is no recommendation, and this is not recommended as a routine investigation. So routine DAT is not basically encouraged, because they would more likely be the routine and the anti-D that may be there would be most likely due to the anti-D being administered to the D negative mother. So if there is a D positive baby in a D negative mother, but the mother had not had a history of red cell, a positive history of red cell allo antibodies, then routine DAT is not generally recommended. However, if they had some antibodies, if the D negative mother had antibodies, then the cord blood sample needs to be checked by DAT and bilirubin and HDFN. So this is one of the recommendations, that routine their DAT testing on cord blood sample should also always be done, taking into account any history of anti-D administration and whether there had been values of whether any antibody had been detected during the course of pregnancy. So all babies born to women who had clinically significant antibodies should be closely monitored for evidence of HDFN, and a DAT hemoglobin and bilirubin concentration should be done at the time of pregnancy. Another recommendation is that D negative women with no immune anti-D should have so D negative mothers who had no immune, but those D negative mothers who have D positive pregnancies, they should the routine DAT may not be done, but they should have an initial FMH test at delivery, and follow-up testing is if required in recommendation with BCHS guidelines for estimation of fetal-maternal hemorrhage, to identify the dose of the anti-D that needs to be administered to these patients. Since at a time, even if they did not have any sort of an antibody during the course of pregnancy, but following birth, there would be, of course, birth in itself would cause for a risk of poses a small risk of even a slight fetal-maternal hemorrhage. So the FMH testing should be done. So basically, if the mother is D negative and the baby is D positive, they would be referred to a fetal-medicine specialist and be monitored throughout the course of pregnancy, and be delivered ideally at 37 weeks of gestation. Then if the mother had clinically significant antibodies, any significant antibodies, and the fetus, the newborn, not only the fetal monitoring was done, but even the newborn used to be monitored with the hemoglobin, DAT, and bilirubin. However, if they did not have any immune anti-D, then D negative mothers with no immune anti-D, then they should be monitored with FMH testing. Initial FMH to be done, and it can be repeat follow-up can be done in accordance with the BCSR guidelines for FMH testing, to outline the in order to determine any requirement of additional anti-D that needs to be given. So this is all about the antibody administration. So most important charts are the ones that we went through regarding the clinically significant antibodies. That is the ones that mention the titers that need to be done, titers that need to be monitored. Then special reference to the KEL antibody, its titration, and its monitoring for HDFN, and also the D-typing for immune or passive. So this is an important chart that outlines how the KEL antigen needs to be monitored, how the KEL antigen needs to be titrated, and the heterozygous father needs to be further investigated for KEL star 01 antigen, and this cell-free fetal DNA, if positive, puts the fetus at risk. And for anti-D, we have this quantitation of the antibody level using these values, and then further paternal and fetal testing, and what puts them, and then they are referred to fetal medicine specialist if they are found to be at risk. And so same is for C. With D, we need to be very cautious about values below 4, which may have a history of HDFN or an anti-D administration. Then we need to then we need to follow them more stringently, whether the values come out positive before 28 weeks or if they are after 28 weeks, what makes them immune and passive. So all those that needs to be taken into consideration. Then if the fetus is during a fetal medicine specialist, they would not only confirm the reports of the cell-free fetal DNA, they would take into account the reports of the cell-free fetal DNA, which suggests that the fetus is at risk. Then they would also monitor the antibodies of the mother during the further course of pregnancy, and also do serial ultrasounds and intrauterine transfusion if necessary may be given. And delivery is recommended at 38 weeks. And then at the time of delivery, if there had been clinically significant antibodies, then we need to do a cord blood ABO and D-typing, and also a DAT and hemoglobin and bilirubin monitoring needs to be done. And if they show values consistent with fetal jaundice, then management should be done along those lines. So this is a gist of the guidelines for blood grouping and antibody testing in pregnancy, and the part about fetal maternal hemorrhage and how it is measured and quantified, and how NTD is administered, that would of course be dealt with in a subsequent session. So with this, I thank all of you, and